Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
Being unable to control bowel movements, called fecal incontinence, is unfortunately a fairly common problem as people age. It is more common among women than men.
What causes it, and what options are there for treatment? Joining us in studio is Mayo Clinic gastroenterologist Dr. Jean Fox. Welcome back to the program, Dr. Fox.
Thank you. Good morning, Tom and Tracy. It's great to be here.
Thank you. Always nice to see you. So, not the most pleasant subject, but fecal incontinence probably apparently more common than most of us know or realize?
Yes, it is. It's more common than most of us know or realize, and it's something that people are not comfortable talking about. So even when somebody has a long-standing relationship with a physician, it might be something that they're hesitant to bring up, and they might skirt around the issue and refer to it as diarrhea or bowel trouble or by some other name because it's so difficult and embarrassing to talk about.
Do we know why it affects women more often than men?
Well, the thought is that it may affect women more than men, in part because some of the problem of fecal incontinence is due to obstetric trauma. But there may also be selection bias in that women are also more likely than men to seek medical treatment for a variety of medical conditions.
Mm-hmm. And true for yeah, you're right.
Well, and that's even worse then, because if men and women have it equally, then men just aren't coming in to see their doctors and suffering with this in silence.
I don't think that they have it equally, but I think, yes, men are probably more likely to suffer quietly or be hesitant to bring it up unless somebody brings it up to them. Or
and their wife takes them into the doctor.
Their wife,
that you need to talk to your doctor about this.
Their wife might bring it up.
Well, because it definitely affects your quality of life.
It absolutely does, and many of my patients will say that they are hesitant to go on trips. They're hesitant to fly in an airplane. They're hesitant to go to family or social gatherings because of the worry about having an accident.
Is it always older people, or are all ages affected?
I'd say that for a variety of reasons it may be more common as we age, but we do see it in young folks as well.
Now, when it comes to incontinence, there are a couple of different types. Is that true also for fecal incontinence? And urinary incontinence, more than one type, true also for fecal?
Yes, absolutely, Tom.
And what are those?
So there's urge fecal incontinence, where you have the urge to go, but you just can't hold it and get to the bathroom in time. And then there's passive fecal incontinence, which is fecal incontinence that might occur more passively. You don't have the urge. It can occur at nighttime when you're asleep, or sometimes it may occur during the daytime, and you might not know it's occurred until you feel a wetness in your clothing or something of that nature.
And so one is urge incontinence, just like there is urinary urge incontinence, but the other one they call apparently passive incontinence.
Yes.
Did you say? And that's because of lack of sensation. Where does that come from? Why is that?
So that can come from a variety of different things. It can come from a neurologic injury, such as a spinal cord injury, or it can come from a variety of neurologic diseases such as multiple sclerosis or a neuropathy of any cause. It can come from diabetes, long-standing diabetes. Fecal incontinence can often be a complication of long-standing diabetes, and it's of the passive nature, and again, it's due to nerve damage, similar to how you might think of any other neuropathy associated with diabetes.
Is one more common than the other, urge or passive incontinence?
I don't know that.
Okay.
I don't know that. I'd say that we might see more people in the clinic with urge incontinence.
Okay.
But oftentimes the confounding thing is people can have components of both. So the same person might present with components of both.
Are you always able to figure out what the cause is?
Well, the first thing we do is we take a good dietary history, because oftentimes diet can be a contributor or a culprit. There are some dietary factors such as the ingestion of poorly absorbable sugars, or
what
sugar
might that be?
substitutes.
Sugar substitutes? Yeah.
Yeah, like excessive amounts of high fructose corn syrup, which will create a large osmotic load for your gut that's too much for the body to absorb, and that can produce a lot of watery stool and urgency. Sometimes excessive caffeine intake can play a role.
Now that's interesting, isn't it? I had never heard that before, that too much caffeine can cause fecal incontinence or contribute to it.
Yeah.
Do folks with fecal incontinence, though, have probably figured out what food and drink affects their digestive system?
You know, you might be surprised, Tracy. I can say that folks spend a lot of time trying to figure out what's the culprit and what's going on with their diet, and might try eliminating certain things. Certain things people are very good at figuring out, such as dairy. People know that dairy is an issue. People may not realize that caffeine is an issue. The other big culprit is soda. If people are drinking excessive amounts of soda pop, whether it's diet soda or regular soda, that can contribute, and people aren't always good about figuring that out.
One of the other causes on the list was a hardened stool that collects in the rectum, impacted stool. Do you see that fairly frequently?
So we do see that a fair amount, and sometimes we will see people who have a history of constipation, and then they've had constipation for many years. They kind of gotten used to the constipation and really have thought of that as being their normal, and then they'll come in with a complaint of diarrhea, and what's actually happening is they're experiencing leakage of loose stool around a hardened stool, and that can lead to seepage or fecal incontinence.
Can you figure that out on a digital exam,
yes,
rectal exam?
Yes, you can usually figure that out on a rectal exam.
And then you just disimpact the stool mechanically?
Yes, and then the important thing is to get people on a good bowel regimen so that their constipation is well addressed, so that that doesn't happen to them again.
What did you call that, a bowel regimen?
Bowel.
Oh, bowel regimen.
Yes.
Gotcha.
Yeah.
And what about patients with diarrhea? I would think that they would be more prone to fecal incontinence if you have generally loose stools.
That's absolutely true. And oftentimes when people present with diarrhea, we go through looking at their diet, looking at their past surgical history, and one of the mainstays of therapy then is to try to help them with solidifying the stool. And oftentimes when people are having fecal incontinence for liquid stool, if you can simply solidify and bulk up their stool, it gives them much better control.
And what about structural problems? And I'm thinking of prolapse of the rectum and a rectocele. Explain that to us.
So prolapse of the rectum and prolapse of the rectum is actually prolapse of rectal mucosa outside the body.
Yes, so part of the rectum comes through the anus and
yes,
comes actually outside.
Right, through the anus and outside the body. And that obviously can be very painful, and that can also result in leakage of stool.
And then a rectocele.
And then a rectocele can be due to several different things. It can be a complication of obstetric injury, or it can be a consequence of chronic constipation and straining at stool for a long time. And essentially what it is it's a herniation of between the vaginal and the rectal wall, and it creates a bulge or a pocket from the rectal area into the vaginal area, and stool can accumulate there.
Is there any place in here that things like inflammatory diseases like Crohn's or ulcerative colitis, any of that plays into this problem?
Oh, absolutely, absolutely. When you're thinking about inflammatory bowel disease, there are more than one thing going on that can contribute to fecal incontinence. One is the liquid stool itself, and then the second is there can be inflammation in the rectum, which causes a feeling of fullness or discomfort in the rectum.
All right, fecal incontinence, a difficult problem for, unfortunately, a fair number of seasoned citizens. There are two types, multiple causes. Our guest is an expert gastroenterologist, Dr. Jean Fox. Time for a short break. When we come back, we'll talk about all of the various treatment options that there are for fecal incontinence and also tell you about 2 or 3 clinical trials that are going on at the Mayo Clinic right now. Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McRae.
We are with gastroenterologist Dr. Jean Fox, and our topic is fecal incontinence. We've talked about what causes it, and there are multiple different causes. We've talked about the fact that there are 2 different types, and now it's important for us to learn what are the treatment options, and let's start with the best thing you've got for it.
So, I always start with the basics, and we always talk about diet and what people are ingesting and what their meal habits are, and we try, if there's something there that brings up a red flag, we try to modify that.
Like sugar substitutes, too much caffeine, too much pop, things like that.
Yes, things like that, absolutely. And the other thing that's very, very important to mention, and I don't want to forget, that we touched upon a little bit before, fecal incontinence is not really a normal part of aging. So whatever you are, whatever age you are, if you've developed this problem, you really should see your physician, and you should have an investigation, and that investigation should include appropriate colon imaging.
Now, the other thing I wanted to ask you about is there are certain people who may not know, even as they age, that they are intolerant to lactose and fructose. How do you find that out? And is that sometimes a cause?
So that can sometimes be a cause. And so oftentimes we might do a breath test to help determine if they're...
B-R-E-A-T-H?
A breath test.
Breath test.
Yes,
Really?
A breath hydrogen test with either a fructose or a lactose load to try to determine if those are part of the problem.
And if what happens if the test is positive?
So if the test is positive, then we might try eliminating those things from the diet.
Well, I mean, do they get flushed, or do they get diarrhea, or how do you know if it's positive?
Oh, pardon me.
Yeah.
So if the test is positive, often patient will have symptoms during the test of bloating and cramping.
Oh, okay.
And the breath hydrogen excretion is measured, and if the breath hydrogen reaches a certain peak during a short period of time, then we know that the patient is malabsorbing that sugar. Now, that said, I'll give a caveat, because the load in that test, the sugar load in that test, is much higher than most people might get in one serving of a food containing fructose or lactose. So it doesn't always give us the answer. If it's negative, we've been able to rule it out. If it's positive, it's worth a trial of eliminating that sugar from the diet and seeing if things improve.
All right, what about hardened stool and constipation? Fiber important, and is over-the-counter fiber, does it work pretty well?
So especially for people who alternate between diarrhea and constipation, we can try fiber.
Fiber doesn't make sense, because if you're trying to stop diarrhea, you'd think that fiber would increase diarrhea.
Well, that's a good point, and many people have that false belief, Tracy. You're not alone. But the issue is, sometimes if people have stools that are alternating in consistency and sometimes hard and sometimes loose, fiber can kind of even it out a bit. And if somebody's tending more towards loose stools or diarrhea and they're going to try fiber, I tend to have them take it with less fluid. And so sometimes that can be helpful. But we have several tests available here at Mayo Clinic to help determine causes of diarrhea, and about 30% of patients with diarrhea predominant irritable bowel will malabsorb bile acids. And so we can test the stool for that with a 48-hour collection and allow us to determine whether or not that person might respond to a bile acid binder, like cholesavilam.
That's a pretty That seems like a pretty simple fix, actually. If
Yes,
30%
it
of the
can be.
people, wow.
Okay, if diarrhea is a problem, are the over-the-counter anti-diarrheals on the market, are they decent?
They are, and they can be quite helpful.
And which ones do you recommend specifically?
Specifically, I would recommend loperamide.
And what's the name that we would recognize?
Imodium.
Imodium, all right. A couple of other treatment options that we've heard about and want to ask you, and one is biofeedback. Is that effective, and what exactly is involved?
So biofeedback involves working with a physical therapist with some electrodes or sensors in the rectal and perianal area to measure muscle tension and help with strengthening exercises. And also there can be help with urge suppression, so that if somebody has the urge, they're able to suppress it. It's less effective in people who have passive fecal incontinence, and we generally would not send patients who have a significant neurologic condition to biofeedback, but for patients with urge and with muscle weakness in that area, it can be helpful.
And what about surgical options?
So surgery for fecal incontinence has been something that's been explored for decades. And we know that in younger women who've recently sustained an obstetric injury, surgery can be quite effective.
You mean if there's a tear in the muscle around the anus, right?
Yes,
Yeah.
related to childbirth.
Okay.
Then surgery can be effective. Later in life, for women who may have sustained an injury during their childbearing years, surgery is not effective. And that's probably for a number of reasons, one being muscle atrophy, the other being
Shrinkage,
nerve degeneration. But they're not. It's not effective later in life.
and we also know that there are good operations for rectocele and rectal prolapse, right?
Yes,
if
there
those
are.
those are the issues, those problems can be solved surgically.
Yes.
Otherwise, it's difficult. And as a last resort, I presume colostomy if all else fails, and they can't control their stools at all. Do you ever do that?
We do that. And often it's for people who have a significant neurologic injury, or people who have a sphincter injury and weak muscles, who are just really ready to be done with it. And,
they've had enough.
It solves the problem. It does solve the problem. It's a big step, and not everybody's ready to take it.
What about the patients, though, that hear you say, and then they think, oh, I don't want to go mess with this. I can't even bear to start talking about it with somebody. There is a colostomy in my future. I know it, or some sort of implantable device or surgery. What would you say to the patients who can just be helped with mild interventions like dietary things or medicine?
Yes. I would say don't let embarrassment keep you from discussing the situation with your doctor.
What percentage of patients are in that category? Any ideas?
No.
Okay.
All right, so we've got lots of treatment options, colostomy being a last resort. So let's talk about, I know you've got some clinical trials going on at Mayo. Tell us about those.
So there are 3 clinical trials going on at Mayo right now for patients with fecal incontinence. And 2 of the trials involve a medical device with or without biofeedback. And the 3rd trial is a pharmaceutical trial. And if people are interested in finding out more about that trial, I can leave you with the name and phone number of our study coordinator who can help connect them.
Let's give that number right now. That is for Kelly. And the phone number is 507-255-6802. And so when everyone starts calling Kelly, she's going to know where that information came from.
So essentially what these are for people who have tried multiple other modalities for treating this condition and it hasn't helped. So these are trials of different things that may help them.
Yes.
All right, 507-255-6802. It's Kelly.
Excellent.
Fecal incontinence is a fairly common problem, unfortunately, among older Americans, especially women. But as our guest has just told us, it is not a part of aging, a normal part of aging, and it isn't a problem that needs to be suffered in silence. There are, in fact, multiple effective treatments to reduce symptoms or to actually cure the condition. Our thanks to Mayo Clinic gastroenterologist Dr. Jean Fox.
Thank you, Tom. It was a pleasure to be here.